Okay, what if you don't hit bone? Well, there's three possibilities if you don't hit bone, but then you did something wrong. Okay, the bottom line is if you don't hit bone, you did something wrong. So one would be that you went too superficial and crossed over. Another would be that you did something that the person has a lot of fat and you didn't have a long enough needle. But crossing over is more common in an obese person. You see, so if I have a 45-degree angle from here, I hit bone. If I have a 45-degree angle in the same place here, I'll cross midline, right? So if you don't hit bone at the end of your insertion, probably you either have to have a longer needle or you have to go at a steeper angle. So in a very obese person, you go 60, maybe 75 degrees. Maybe in a very obese person, you actually have to come in closer to the midline to get there because they're super obese. Okay, so that's a bit of a challenge. The same idea when I was talking earlier about a crossover of the paraspinal mapping. So looking at the blue, this this is rather typical for an L5 radiculopathy. And what I want to highlight is when you are at L5 and you're going up, you see you might be coming up into the L4 area. So the top part of L5 might be normal. Okay? And in this person with just an L5 radiculopathy, when they're at the L4 level, they might be crossing over and having abnormalities from the L5 muscle. So there can be this overlap. The overlap is bigger in obese people because there's your sacrum, I guess. Okay? So if I'm going straight in, 45 degrees cranial, 45 degrees caudal, I'm going like this and if the surface is here, okay, then I'm going straight in, that way, that way. But if the surface is up here because the person's obese, I can cross way over a level too far. That shouldn't bother you. That's kind of typical, okay? The other question somebody had was about polyphasic motor units in the paraspinal. Even more less useful unless you're seeing myopathic motor units, right? If you see small myopathic motor units, that's interesting. First of all, you don't need them. Paraspinal mapping is 95 to 98% sensitive. You're looking for the other 3% sensitivity. There are polyphasic motor units in normal people, so if you start looking, you have to have a set of normal values, which have been made for certain muscles in the back, but you're not going to be looking for 10 motor units in each multifidus muscle. And that's the third thing is, to go and try to recruit motor units hurts. You're not going to get them to relax again, right? So I would not, except for under very extreme circumstances, I would ignore any motor units I see in the paraspinal muscles. I think we don't know what the norms are, we don't know where you are exactly in space, and trying to find them and get routine about it is kind of a mess, not so good. So, good, he was wonderful. So with our friend here, what we have, and
the second patient.
Okay, yeah, but hello.
So, these young women, very positive, very active.
Good.
But
good.
she has a long history.
Aha.
At 12 years old.
Oh, just for one moment, I just want to wrap up the last case.
Okay.
Please grab a seat.
Please sit down.
So in our friend there, we're pretty confident that there's not a spinal problem. We're pretty confident there's not a diffuse spinal problem. But you have, on a previous EMG, what looks like a distal predominant polyneuropathy. You could imagine it could be a sciatic neuropathy and a femoral neuropathy for the hip replacement too, right? But it's not in the spine, I guess. And the rest of it you've figured out on your own with us. So that's what that case was about. Any last questions about him? He was normal, I guess. Yeah.
About last question.
Yeah.
About the last patient.
Yeah.
He has a cramp in his cruel.
Yeah.
And you said that there isn't muscles paraspinal by S1.
Yeah.
What about S1?
Thank you. Very good. Yes, you're right. You're absolutely right. I could have missed an S1 radiculopathy. Thank you. I would have tested the gluteus maximus or some other muscles. Yes, that is absolutely true. Good job. Better than me. I was lost in teaching. Yes, it could have been. It could be an S1 radiculopathy.
Yes,
but I think
because the spontaneous activity in the tibialis anterior and the
yes,
vastus medialis.
that's
So
right. That's
that's
right.
why it's not
But-
the C1.
Right.
У него была спонтанная активность в тибиалис антериор, у него была в вастус медиалис и двухсторонняя. Правильно, Юлия Ивановна? Юлия Ивановна, где там была? Это не мой пациент, но я знаю, что была спонтанная
Тибиалис с двух
активность.
сторон была.
Учитывая сниженные
да.
моторные, учитывая сниженные, насколько я слышала, сенсорные.
Только амплитуды, нормальное проведение пациента.
Да,
Признаки.
ну,
Ну,
это нижней
аксональную
границы нормы.
полинейропатию никто не
У него же
отменял.
полинейропатия, я так понимаю.
Да, ну мы по электромиографии мы выставляли
Может
полинейропатию.
быть спонтанная и тибиальная.
Это может быть.
Да, про это
Мы
я просто...
про корешок S1
Да.
говорим. Что...
Да, а как отдифференцировать СДЖ?
когда и вообще ничего нет,
У
и
него
просто
клиника
S1.
На фоне полинейропатии.
Он не может вставать
На
прямо.
фоне полинейропатии.
Может быть, есть еще.
Двухсторонняя
S1 может быть у
И
него есть.
односторонний.
У него с одной стороны, да?
Он же не может встать на
Я
носочек.
думаю, что,
Да.
наверное, нет. На фоне полинейропатии, где есть везде спонтанная активность, изменения нейрогенные, можем догадываться.
У него
Но здесь поможет МРТ.
подагра еще ко всему. Ну да, вот как такой
Нет, он к этому не имеет
метаболизм, да.
отношения, он на носу. Но понимаете, в чем дело? У таких пациентов, почему у нас сложность с ортопедическими больными, у них очень сложно проверить, вообще двухсторонний ли это процесс. Значит, он сейчас практически эту ногу щадит, особенно если имплант ставили 3 месяца назад, да, он вам и на здоровой не станет на носочек.
У
него
сила нормальная на здоровье.
Сила нормальная, нарушения чувствительности нету, ахилла с двух сторон снижены, отсутствуют. Понимаете, тут
Нет, имплант у него слева.
Да, а
боль
второй
справа.
сила у него по S1 абсолютно нормальная. Мы
Нет,
уже
так он же
смотрели
говорить
это.
не может встать.
Ну, он может говорить все, что угодно.
Нет,
Доктор
это
проверял.
Он был слабый, он не мог на носочек.
Ну,
Нет, он сказал нормально. Is that the previous patient has a weakness in the left?
I think so. I thought his big toe was a little bit weak coming up,
Он поднимал,
maybe
говорит,
going down.
немножко слабее.
and I didn't do something that I always do because I'm in a crazy situation. Plantar flexion, you know, these muscles are very strong, right? This one could lift probably 150 kilos if I had to, okay? So I'm always worried that I'll miss weakness, that I will not detect weakness in the plantar flexors. So what I'll usually have patients do is go up on their toes 5 times. And that's not even perfect. You'll still miss some things, but I didn't have him do that. And apparently he's weak in plantar flexion. Yeah.
Можно я спрошу? Как я понял, вот то, что говорил Юрий
Я не
Владимирович.
смотрела этого пациента, вы меня
Да, нет,
спрашивали?
нет, я просто, чтобы все, может, кто-то подскажет. Полиневропатия у него есть, там мы согласны, спонтанно, активно все. Но у него клиника неврологическая радикулопатия. Мы это не подтверждаем при исследовании параспинальных мышц. Есть полиневропатия, нет полиневропатии. Если у него есть клиника радикулопатии, мы должны были найти изменения. Мы не нашли.
Нет, почему?
Он
В S1
то, о
мы
чем
как раз
говорил
именно
доктор.
как раз не могли
Это
найти
то,
в
о чем
S1.
Но мы не нашли, да.
Так нет, параспинальные мышцы мы не можем проверить S1.
Да.
Мы только глютеус должны были поставить иголку и посмотреть, есть ли там S1. S1 не имеет параспинальной иннервации.
Это раз, и я вам честно скажу, у нас очень много таких пациентов, и у вас, наверное, тоже в нейрохирургии. Я не могу сказать, что у него стопроцентная клиника радикулопатии S1. Что, только крампи, вот, которые сказали, что его беспокоит? Но меня тоже беспокоит, у меня нет радикулопатии S1. То есть здесь вопрос
как
очень
дифференцировать,
такой,
да.
да. Давайте уже девушку отпустим, потому что мы начали дискутировать. История, well, I will on
Yes,
English. The history is very long, really. 20 years ago, she fell down from the tree, and the doctor, they made the MRI,
Yeah.
and recognized the spondylolisthesis.
Okay.
So she lives with this spondylolisthesis about 20 years. She has sometimes a pain, lumbar pain, but she has a conservative treatment, massages, physiotherapy, rehab,
Yeah.
so
yeah.
everything was good.
Yeah.
But 3 months ago, what did you do? Nothing? Dancing.
Нет,
What did
ничего.
you tell me?
Ничего.
Jumping.
Нет, я просто шла по улице 3 месяца назад, и это случилось на новом месте.
Ага.
А до этого я
ага.
всю жизнь
And
занималась.
3 months ago, she was walking down the street
Mm-hmm.
and just felt the pain,
Ah,
and just like her legs are weak.
yeah,
You fell down to
Да, я
упали?
упала, да.
She
yeah,
fell down.
yeah.
So she was at home one day. After that, стало лучше?
Нет.
Well,
Боли.
ты
и
выходили,
слабость.
выходили
Ну, я
после
ходила,
этого.
да.
She walked.
Mm-hmm.
She went to the doctor, but she said that now she felt a bigger,
Pain.
intensive
Yeah,
pain in the lumbar spine,
Yeah.
and it's irradiated on the back of the legs,
Mm-hmm.
but mostly in the level.
Yeah, yeah. What, can you walk as far as you want to? Walk a kilometer?
Walking the distance, I was asking her.
Yeah.
She said that she can go even 5 kilometers.
Ну да, до 5 километров. Ну, при том, что я хожу каждый день. до
But
10.
after that, she has lie down for one day.
Ah, yeah, yeah, yeah. So, let's see. First off, spondylolisthesis. How, in an adult, not a teenage girl, but in an adult, how much of a spondylolisthesis must you have before it even correlates with the presence of pain? A grade 1, you know, spondylolisthesis, right? Grade 1 means it slips up to this far. Grade 2 would be halfway. Grade 3, 3/4. Grade 4, or spondylopsis is out here. So, grade 3, grade 2, okay? A grade 1 spondylolisthesis has no correlation with pain in adults. So if I see a grade 1 spondylolisthesis, I say, great, let's go find out where she hurts. I'm not so sure. I don't say, I see a slippage. So the first question is it, you know, is it really, is it more than grade 1? Okay, now, it's very complicated. You can have pain in a grade 1 spondylolisthesis, but if I see just grade 1, I'm immediately looking for what else it could be, right? So what else can cause mechanical back pain?
You know what?
Yeah.
What I forgot,
Uh-huh.
and it's really.
Important.
Thank you.
Yeah, good.
Уже за 3 дня important. So she has a urination problem.
Oh, yeah, yeah.
Yes, and it's about 2 months.
Mm-hmm.
And what else? What did you tell me? And she has a numbness
Yeah.
in
yeah.
both feet.
Yeah, yeah. Right, so this is sounding S1, 2, 3
Mhm.
a little bit, right? Yeah. Again, my brain is constantly fighting what's obvious, right? I'm constantly going, spondylolisthesis, what else? Right? What's the saying? Common things happen commonly. So it's probably the spondylolisthesis causing slippage, causing nerve damage, causing pain. But I want to think of other things. I want to be sure we're not missing the polyneuropathy. Maybe the back pain is from the facet joints. Because if we just assume it's a spondylolisthesis, you could have surgery or something and it wouldn't fix the problem, right?
А какой вам
So-
сейчас диагноз еще выставляют? Потому что
Мы делали тест, а до этого пытались
стеноз у вас был там диагноз, нет?
колудить. После этого колудить.
Мгм.
Да, вот его мне поставили невропатолог месяц назад, но
Она к нам только
герпевирусный.
вчера пришла, поэтому мы ее тоже
Мы
не
отменили
не
герпевирусный, мы
осматривали.
сходили в инфекционную, вот съездили, там сделали все обследования, только пункцию не проводили. Все.
So the doctor neurologist
Mm-hmm.
suspected like virus infection, maybe like
Another,
herpes, don't
another
know.
good thought, right?
Mhm.
Right? Again, I really do this all by myself, even when nobody's watching. In my office, I look at the brain and the spinal cord and the roots and the plexus and the nerve. I just every case, I just kind of look at the person and go. Just it's a habit I've gotten into. Right. So you think about, could this be a polyneuropathy? Could this be a viral thing like this? Right. Again, the spondylolisthesis is the interesting thing. Let's say that we prove that the EMG is positive. Okay. What treatment should she have?
Какой
А я же говорила, she had a conservative treatment.
Mm-hmm.
Не steroids, как там не стероиды называются? Inflammatory,
Yeah.
physiotherapy.
Great. Super.
Плановое,
Super.
там,
Yeah.
корсет периодически.
The surgical options, there are two ways to look at surgery. One is well, no, that's getting even too fancy for me. That's too much. One is it's an emergency, right? When you hear bowel and bladder loss and progressive sensory motor loss, that's an emergency. You go yesterday, which is too late. It's not though. Okay, when it's not progressive, it again becomes something that usually is not a surgical emergency. So there's not a rush. It's not like she has some bowel and bladder complaints, therefore she has to have surgery. Because the only real emergency is cauda equina syndrome, which is progressive neurologic deficit. So one is emergent surgery, no. The other is surgery to treat her current complaints, right? And that might, if the spondylolisthesis is big and the EMG is positive, that might be a decent option. And that would be probably just a laminectomy, a fusion of a spondylolisthesis. Why? If you open up the back of the spine, you have all the room the nerves need. Huh? And a fusion means that the level above will get degenerated as she gets older. She's a younger woman, okay? Now, I'm not a spine surgeon, but more and more the research on fusion in the lumbar spine is not very good, okay? There was so maybe a little bit of a long, short story. There's only one treatment for acute back pain that's made a difference in the long term in a randomized trial, okay? The treatment is my friend Åge Indal, the Norwegian rehab doctor, talking to the patient. And here's how he talked to the patient. He said, if you have back pain, you should go take a walk in the woods. He says, if you have back pain, you might as well go to bed. You might as well have sex while you're waiting to get better. He's making jokes because are you sure you don't have cancer? He's not doing that. He's going, I understand, I respect that you hurt, but don't worry, don't worry. To doctors, he will tell us, who the hell put frontal lobes in front of a perfectly good brain stem? The brain stem and the spine have been together for billions of years without a frontal lobe. Why do we use our brains to think about back pain? And indeed, when he spends about 15 or 20 minutes talking to the patient to ignore how you lift and how you bend and how you stretch, 2, 5, and 7 years later, that population has better outcomes in terms of pain and surgery and disability than the people who were the control population. The control group got the Swedish back school. Here's what's wrong, here's how you stretch, here's how you lift, here's how you bend, here's how you use ice pack. The control population got us acting like smart doctors. The treated population, and by the way, we know that doesn't work. Teaching them that stuff does not change the outcome. We know that. It is a controlled population. He basically told people not to be afraid. Keep moving, okay? And his outcomes were better. So you never want to tell patients, don't act smart about back pain. You're safe, don't worry, I know it hurts, you'll probably get better, is the best thing you can say. So I mention that because a few years ago, the Volvo Award, which is now the Issels Award, was given to a Swedish group that had a randomized trial of lumbar fusion versus not getting lumbar fusion in people who, they qualified for a fusion, half of them got a fusion, half didn't, and the people who got a fusion had better outcome. The outcome was return to work, and the people that got a fusion had an attending surgeon direct them to return to work, and the control population went back to their primary care doctors who did not direct them to return to work. So although they got the international award, we were all very angry because we said, this is a controlled trial of telling people to go to work versus not telling people to go to work. And by the way, you cut open their backs. This is not a fair trial. So Åge and the Norwegians then did a randomized trial of the Åge talk plus a half an hour of physiotherapy versus fusion. No difference in outcome. In England, Jeremy Fairbanks reproduced the study. It's not just Dr. Indal, who's a fun guy. Jeremy's serious. Talking to the patient to tell them not to be afraid and a little bit of general exercise versus lumbar fusion, no difference in outcome. Okay? And so it's scandalous. Not that there are people I believe needs fusion, but it's pretty scandalous. Okay? Then a number of studies have come on with spinal stenosis, maybe not with spondylolisthesis, showing that simple laminectomy has the same outcome as a fusion, except less morbidity, right? So in people with uncomplicated spinal stenosis, a simple laminectomy is the way to go. You don't need to stick the bones together because you get more morbidity, and in the long term, fusions kind of do bad things, right? So probably if she needed surgery, I haven't looked at her films, it would probably just be a simple laminectomy. And the surgeons love their cages. They love them. Yeah, it's the Americans that caused this. I'm sorry.
Well, she's young, it's progressing, the listhesis, so she wants to be active. She's a dancer, she was an ballet dancer.
My
so
daughter's a ballet dancer.
She wants...
Yeah, okay. So do you think spondylolisthesis progresses in adults?
Well, I don't know.
No.
This is her spine doctor say.
Yeah, no. Spondylolisthesis does not progress in adults. Okay, in children, in 20-year-olds, 18-year-olds, it does. And of course, it happens more in dancers, right? So we're not ignoring this at all. I just want you to I want to break your thinking that you learned in school. Okay? Yeah, spondylolisthesis. We did a survey of some of the world's spine experts. You know American football, the crazy guys with the helmets, bam, right? And they get spondylolisthesis. So I had my fellows call up a bunch of the world's experts on spondylolisthesis and said, if you have a college football player with a spondylolisthesis and significant pain, would you still let them play football? And we thought they'd say, oh no, paralysis. And every single one of these spine surgeons said, oh, it might hurt, but they won't slip. It might hurt, but they won't slip. So there is no sense that this will progress. If we're wrong, it'll be something different. Surgery still may be the right answer, but not because you're afraid of the future, but because of what's happening right now. And I'm concerned about your symptoms. I'm worried about those a little bit. Good. Can we examine you? Just look at you? But you speak some English. Thank you.
She understands everything.
Спасибо.
So be very careful.
I know. Trouble. Would you take off your
Take
off your shoes?
Снять, да?
Yeah. So we have back pain, which may or may not be treated surgical. We have bladder and bowel stuff, which might need to be treated surgically. We have maybe nerve stuff in the legs, which might be surgical. And so our EMG is a really appropriate test. Can I have you stand up and come over here and look this way? Okay. Can I pull this up, okay? Yeah?
Можно он поднимет? Да. Вы же все понимаете, вы же...
So I can see her spondylo. It's a grade, it's my x-ray machine. It's a grade 2 spondylo, maybe grade 3. So she's got more than a little spondylo. Are you tender out here? Yeah? Is that a big problem during your day or just me?
Беспокоит в течение дня?
Не очень. Тільки коли нажимаю. Да, когда нажимаю.
Poke the toe, poke the troch, poke the truncator. How about back here? Smack the sacroiliac. Is this something that bothers you during the course of your day?
Вот это да, чаще всего, да, в
Yeah.
течение дня.
That is not a spondylolisthesis, that is the sacrum, different body part, right? How can I prove that I'm right? The only scientifically valid proof is an injection of anesthetic into that joint under fluoroscopy. And if she gets off the table and says, my pain is all gone, wouldn't it be a shame for somebody to operate on her
Well,
back?
not all the time. And we're doing this many times.
Yeah?
And sometimes when we really see
Yeah.
that the clinic is of sacroiliac,
Yes, sometimes it will
we
be
are
wrong.
doing the lidocaine.
Sometimes it will miss this, you're saying.
We
yeah.
do with X-ray
Yeah,
in the
yeah.
navigation.
And your experience is, what do you find? I didn't quite understand. You find that it is good or not so good?
Sometimes it doesn't work.
Sometimes it is positive, but you thought it would be negative, or sometimes it is negative. And
Sometimes it's negative.
Yes,
It sees
yes,
the clinic,
yes.
but sometimes it's negative.
yes, exactly. Its specificity is quite good. Its sensitivity, I also see that it misses. Okay, but this is her pain. This is the sacroiliac joint. Okay. How about here? How about up in here? I'm palpating her spondylolisthesis, and she doesn't hurt there. Okay. Now. The other, so I said, my rhyme, you stay right there, okay? I'm going to grab with my knees, okay? So I poke the troch, smack the sacroiliac, I'll whip the hip when she's lying there, and I'm going to upset the facet. Arch. Does that hurt?
No.
Uh-huh. This way? Arch? No? Okay. So, sacroiliac, I think. Come sit here, please. Scoot back a little bit. Good. And the last one is I whip the hip. What do you think of this? Is this painful? Back there. Uh-huh. So again, we're causing sacroiliac pain, but we're not having groin pain from the hip, right? The hip joint, the trochanter, and the sacroiliac joint are kind of a triangle that work together. So you'll see people that have no pain in their hip, but x-ray really bad arthritis in the hip, right? They don't complain of hip pain. And you'll see that they have trochanter bursitis or tendonitis, and they have sacroiliac pain because they're walking asymmetrically, right? Testing how strong you are, okay? Curl your toes down. Nope, just the toes. Yeah, good. Hold. Down. Hold it. Good. Toes. Toes up. Toes up. Push forward. I'm skipping part of my test. Push forward. Hard. Good. Pull backwards. Pull backwards. Squish together. Honk. Push apart. Lift up. Lift up. Knees together. Ankles wide apart. Hold. Up. Hold. I'm going to push it. Yeah, good. Thank you. Relax now. Reflexes. Yeah. Now, bring your heel back just a little. Just a little. Okay. Can you see my medial hamstring reflex? A little bit back. See, jump back. I can feel it maybe, okay? All right. You see? Right there?
Can you show
Not so
me
much. Yeah, just a little bit. Not too much. Just a little. Good. And she jumps back. I can feel it more, huh? Okay. And I didn't check your ankle up. Good. Ankle up. Okay. So, now we're left with, so what if I do find a positive EMG? I'm still going to have physio work on her sacroiliac and her trochanter, and maybe even do injections to prove I'm right or wrong before I let anybody do anything with a knife, right? Just because, But, can we do our testing? I use a needle in muscles, you know? Hurts a little bit. If you ever need to stop, you go time out, okay? Lie down with your stomach here. Yeah.
В данном случае, быть может, надо несколько подушек.
Лордоз выраженный. Ну, это пусть Haig решил. А тут удобно?
Да.
But you can see the spondylolisthesis in a dancer, huh? Make a mark first. So, I'm feeling, and actually, would somebody else feel? I'd like to have somebody else try. Do the palpation. Yeah. Okay. So, find her sacral base. Yeah, and you can make that mark if you want. Great.
Мы вас порисуем.
And then feel spinous processes. And just right in the middle. You just find the bones. Again, if you mispalpate and you're half a level up or 2 levels up or 1 level up, you're still testing everything. All you want to be sure about is that you get over the sacrum, because you'll miss L5 if you don't go over the sacrum, right? You can't get L5 if you don't get over the sacrum. So if you're 1 level up or down, maybe your confidence in saying it's L4 instead of L3 is low, but your test is still positive.
Здесь рисуем этот кружочек. Не-не, вот полосочка, вот тут вот между позвонком у нас.
Ну, вот так.
Не-не-не. Там черточка должна быть.
Так?
Да.
Хорошо.
А теперь вот тут туда, а ты опять чувствуешь? Так,
Я не сама чувствую.
Да, я тоже вам хочу сказать, что у нее так дальше.
Там, где промежуток,
Да, да. А потом мы рисуем остистый отросток. Так хорошо у вас получилось.
Hard to tell. Maybe there's one more here.
Может быть, выше этот крестец.
But if you're wrong, you just make sure you test far enough caudal to not miss something, right? you know, about 5% of people have an anomaly of their lumbar spine, like a 4 vertebrae or 6 vertebrae, right? And what's very complicated when you do EMG is you say, let's say, the tibialis anterior and the vastus medialis are abnormal. You go, well, they both share L4. But that's a neurologic construct. And if the person has 4 vertebrae or 6 vertebrae, you can also have 5 vertebrae and have a prefixed plexus or a postfixed plexus. So there are a lot of reasons why your neurologic construct that we learned in school can be wrong for a person who either has an anomaly you see on an x-ray or an anomaly you don't see because it's just the way the spine is wired, right? With paraspinal mapping, it kind of goes like this. I found it here. I don't care what you call that bone, but that's where the nerve is coming out, right? So there's something, if you know there's an anomaly, you know, 6 vertebrae or 4 vertebrae, you can kind of map out and say it's the one you're calling L3 or it's the one you're calling L4 because it's anatomically true. It's not a theoretical construct of what the L4 nerve root innervates, right? It's like that spot. Great, so you're going to go 2.5 centimeters to the side.
Excuse me, I have a
Yeah.
question. But if you even little bit move, just you will do not right.
Yeah.
So it's a
No,
not 0.5 centimeters.
you know, it's true. I've gotten more confident in my palpation. Maybe I'm foolish, but maybe I'm wrong. You know, in other words, the studies that look at trying to correlate palpation for anatomical levels with actual levels on an X-ray show that the reliability of the clinical exam for the level is not so good. There are many studies with physiotherapists, etc. I think I'm better than that. Maybe because I'm not using the rules. Like the rules would say find the ASI or the iliac crest and draw a line across, you know, this kind of thing. I don't do that. I'm actually feeling the bones. And the second
But
thing is,
sometimes you can feel when
Yeah.
it is obesity or
oh yeah, no, then it's not. Then it's very inaccurate. But in a thin person, I'm feeling the bones themselves and the sacral base, and my EMG needle, which is my ultrasound probe, is helping me to see whether I'm right or wrong. I should probably do a study. We did one, our cadaver study that said we were very accurate, but I should probably do one in live humans to see that I'm right. But I've got more confidence than that. I kind of feel like, yeah, I kind of know where I'm going. In skinny people, for sure. As people get to like my size, maybe not. So where are you going to mark your needle placements? 2.5 centimeters to the side of each of those. Yeah, yeah.
Конечно, конечно, они так и будут, но им нужно подняться
No.
на один выше уровень, на один ниже. Правильно?
Centimeters?
5S1 или L4. Выше
So-
подняться.
Maybe not. It's okay. Okay.
Я же недавно
I
ничего
think
сделать не... Да.
I think that this is more than 2.5 centimeters. Now, the U.S. military, their rehab residency, they actually give the residents a military paraspinal mapping measuring tool, which is a little piece of plexiglass 2.5 centimeters wide. And it's got a lanyard, so the doctors carry this around in the EMG lab to do paraspinal mapping. So, yeah, this is probably a bit wide, but you'd find out, because you'd put your needle in, you'd get to the hub, and you wouldn't be touching bone. And you'd say, oh, I'm too far out, I'll go in. So I would go in a little bit. Maybe, yeah, you know. Yeah, that's probably good. Okay. Then, if you're okay, I'll do one level, and we'll have some other people do other levels. Super. Yeah. Okay, yeah, so here we go. Perfect, 2.5. Good job.
Второй
Okay.
раз просто в это.
Let's see, I have a needle back here. And I'll just do one level, and we'll move from there.
Будете чувствовать укольчик. Будет неприятно, скажете.
So, I'm going to put a needle in your back, and your job is to relax your muscles, okay?
Расслабьтесь полностью.
Шумит машина. Просто ей не делали еще МРТ, она не знает, что это такое, поэтому...
All right. Are you okay?
Yeah.
All right, here we go.
Она, she's very positive,
I think so,
very...
yeah. Now I just got muscle. Hip bone. So maybe 2 insertions of muscle.
Неприятно.
Muscle. muscle, bone. Muscle, 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 muscle. I fell off the cliff. I fell off the sacrum, okay? So the sacrum is someplace right about here. If I were to go further down, because maybe I'm not so sure, I'll always just go one more level down if I'm not sure. This is the bone. This is it. Not bone. And I hit bone pretty quickly, so I know I'm over the sacrum. So I'm way down over the lowest part of the multifidus, which almost nothing. Okay. So again, what happened here, if people didn't get it, is when I was inserting straight across, I went fat, 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 muscle, muscle, bone. When I went down this way, I went fat, 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 muscle, muscle, bone. When I went up this way, I went fat, 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 muscle, 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 bone. I had 4 or 5 insertions through muscle, which means I fell off the top of the sacrum into L5. So I'm pretty sure the sacral base is right here, a little bit lower than we thought at first. And I would only know that not because of palpation, but because my ultrasound probe told me. Does somebody want to do a level? I'd like, by the time we're done, for everybody to have a chance to do a little bit. So grab a, unless you really don't want to, grab a glove. Gloves are good. Let's see. You're tough. Good.
She's a good girl.
Yeah, yeah. Yeah. Completely unnecessary. Yeah. Okay. Now let go, let go, let go. Okay, do you like the angle? Yes. Good, I like it too.
Угол хороший.
Bone or no?
No.
So maybe you were a little too deep, but that's okay. Pull out to the surface and come up. Yeah. You were a little too steep, but I wouldn't have thought so. It looked good to me. All the way out, all the way. On the way back, you just pull it out.
If she
to the
does not
surface.
took a bone, so she just need to move a little bit.
Pull it out to the
Yes,
surface
and
move
need
it.
the angle.
Yes, yes.
До кожи, до кожи.
So is it obvious? On the way in, you're inserting. On the way out, you just pull the needle out. You're not looking for anything on the way out.
И чуть-чуть больше угол, да?
Let go. Let go. Yeah, you like that?
И дальше.
Okay,
Стоит,
good.
он
Yeah.
проверяет, чтобы она не упала.
Yeah, good. No?
Не дотронулись?
Then maybe.
She does not feel the bone.
Here's the bone. Maybe you need to go at a steeper angle.
Я же говорю, угол немножко.
Yeah, right there I hit bone, I think. You feel, see if I hit bone.
Yes.
Okay, yeah. So we're still out. Okay, go ahead. You can go come up this way.
Почувствовать тишину.
Okay. All right. Good. Somebody? So
Ну, терпимо. 4 точки еще.
just because of our spondylolisthesis question, will you do this side right down here? Okay. Yeah. 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 So let's see if she falls off the cliff.
The angle is too much.
I think so. I think so.
Да,
But let's see.
очень сильно наклонили иглу.
I like it, huh?
Now it's
So this is a case where I might find my 75 millimeter a little bit easier. Just a little bit of adipose over the back here. She's not a heavy person, but it's a little hard to get. Or I might have to take, if I only had a 50, I might have to put it in closer to the midline than 2.5 centimeters. Yeah, okay. Come out and redirect. Yeah. Okay.
принципе, был с того, что был...
Опять, ну конечно. Пускай сразу на каждом уровне.
Ну,
Вот так.
я понимаю, в зависимости от выраженности. Ну, все равно что-то...
Now
Ну,
let's,
да,
let's pretend.
То есть прекрасно.
Positive ways. First question,
Not
1 second. Okay,
And
we're
not-
pretending. Yes, 1 second. So go
Let's
back
try
up and
one.
try again. Try, not all the way, just a little. Yeah. Okay.
Опять наклоняйте низко сюда.
Okay, there it is again. Yes, more than 1 second. Now, are you in the S or the M? What do you think? Keep
Вы специфик или
No,
M? In a
M.
mixed.
Yeah, okay. This is the whole logic, right? You got it.
А специфика, когда вот уже
Когда глубоко вы попадаете... Нет, ну, это совсем не считается.
то есть
Когда
уже, да.
оттолкнулись от кости.
Yeah. After she finds the positive waves, then she can pay attention to how much more she has to insert. And so after she's done, she can know for sure she's in the last 1 centimeter. Good job.
Нормально? Самое главное, что мы ничего не слышим плохого.
Может, у меня хороший.
Okay? Yeah? Okay. All right. Somebody? By the time we're done, I hope everybody tries once.
Еще один
You don't have to,
уровень.
but
Один уровень у нас остался у девушек.
we have 2 more cases, correct?
Yes.
Yeah, okay. So, yeah. It really is a mistake. Now, our question is about L5 and S1, right? And so, if you weren't careful, you could just do L5 and S1 and quit, okay? Maybe in a young, healthy, simple case, that would be okay. You wouldn't be using our normative values, but if it was normal, you might be okay. It's usually just no big deal to go up and do L4, L5, L4, and L3, just to do all of one side and get on with it, right? So I try not to be creative. I try to just, if I'm going to do the back, I do paraspinal mapping and do all the levels. I don't think I'd yell at you. I would not be angry if all you did was L5 in her. I understand. The only thing we're worried about is an L5, S1 spondylolisthesis. But it takes so little time that you just and you're done. And so I usually do the whole thing all the time. Here you go. Maybe palpate, feel with your hands to be sure you like where you're going.
5,1 нет, хотя бы на 1 подняться выше и увидеть что-то изменение. Этот звук я сама пугаюсь.
Владимир Ильич, как профессионал, да?
The angle is
A little shallow. Not, yeah,
a little
yeah.
bit. А вы почувствовали?
Yeah,
А
it's a
потому
little
что
bit.
нагнули очень иголку.
You hit bone?
Ну, похоже, да.
Ну не 45 явно.
I thought of something
Почему не
too.
45?
45.
Но не почувствовал эту.
А,
ну,
не
чувство
хочешь, не
боли.
Я уперся, но я не знаю, чем я это уперся.
Ну, вы его чувствуете?
Так, глаза не закрывать, а то я уже испугалась.
That's too shallow.
Это у меня один так пациент
Yeah?
закрыл глаза.
Good. Like this. Good. Okay, pretend. Positive waves, reproduced. Okay. Now, stay there. All done. You reproduce. We pretend. Pretend. Okay. S or M? Where are you now, do you think?
S.
Go find out. Now you go find out. You put the needle in further and find out.
No, it's M.
Here, okay.
It's M.
Yes. I think so. Nerve end plate? Yeah, nerve. Ouch.
Вот эти вот.
Nerve end plate, I believe. And still, end plate noise?
Ага.
It's sputtering too much.
Звучит по-другому.
Again, nerve end plate. We're getting ready to. Yeah, better. Bone. Excellent. Yeah, yeah, good.
Ну, конечно, нет.
Хотя бы услышать.
А?
Хотя бы услышать какие-то были.
Ну, а где же мы найдем?
Thank you. Okay. Wow, fantastic. Maybe one more person, and we won't do all of her. If somebody else would like to do one more? Are we done? We could go to the next patient. Thank you so much. Let's see. Oh, I'm on mic.